Welcome to the deep dive. Today we're tackling anorectal abscesses, that really uncomfortable collection of pus, well, where you'd least want it. Sounds a bit grim, I know, but we're using these anorectal abscess revision notes to, pull out the essential facts for you, clearly and quickly.
Exactly.
Think of it as your shortcut to understanding what this condition is all about, from how it starts right through to potential issues if it's not, well, sorted.
Okay, so let's start right there. What exactly is an anorectal abscess?
Well, simply put, it's a collection of pus right near the anus or rectum.
Okay.
The notes highlight a few main triggers, things like an insected anal fissure, maybe some STIs, or quite commonly blocked anal gland.
Blocked glands.
Yeah. And what's interesting is they're not all identical. They can actually show up in different spots around the area, like perianal, Ischiorectal, Intersphincteric,
Yeah.
a few others too.
So the specific location can tell you something.
Sometimes, yeah.
Yeah.
It can hint at the cause, maybe what complications you might need to look out for. Got it. Location matters. So what actually gets this whole bacterial infection started? What are the key causes?
So the core issue is bacteria managing to get into those little anal glands.
Right.
Think of it like a blocked pipe almost. If it can't drain properly, things can get, well, infected.
Makes sense.
Our notes list things like Crohn's disease, diverticulitis, STIs, even just trauma, maybe from anal intercourse, as potential starting points.
Okay.
And also, if your body's defenses are a bit down, maybe you have diabetes or a weakened immune system, or if you have chronic bowel issues like constipation or diarrhea or IBD, you're just more susceptible. HIV/AIDS is another factor mentioned.
Okay, so a few things can increase the risk. Who's most likely to encounter this then? What are the major risk factors we should know?
The really big one to remember, and the notes stress this, is the link to fistula in ano.
Ah, yes, the fistula connection.
Exactly. It happens in about 40% of cases, apparently. A fistula is like a little tunnel that can form after an abscess drains, or sometimes alongside it.
40%, wow.
Yeah, it's significant. The notes briefly mention Goodsall's rule for classifying fistulas, but the main takeaway is that link.
Okay.
Also, specifically thinking about the UK, people with diabetes, those who are immunocompromised, individuals engaging in receptive anal sex, and definitely those with IBD are considered higher risk groups.
Right. We know what it is, the risks. How does it actually develop?
Yeah.
The pathophysiology.
It's pretty straightforward, actually. You get a blocked or inflamed anal gland, and it traps bacteria inside.
Okay.
Those bacteria then multiply, and your body sends in immune cells to fight back. That mixture of bacteria, dead tissue, and immune cells is what forms the pus.
Got it. Simple but effective, unfortunately. Now, if someone presents with these kinds of symptoms, what else might be going on? What are the main differential diagnoses?
That's a really important question. Conditions like inflammatory bowel disease, so Crohn's or ulcerative colitis, they can sometimes cause similar issues like pain or discharge down there.
Right, IBD?
Exactly. And although much rarer, you always have to keep things like anal carcinoma or even colorectal cancer in the back of your mind, though they usually present quite differently overall.
Okay. So who typically gets these abscesses? What's the epidemiology look like?
In the UK, the notes suggest it's most common in the 20 to 60 age range.
Okay.
And interestingly, men seem to get them about twice as often as women.
Oh, really? A 2.1 ratio.
Yeah. And there's another link. If someone has a particularly deep rectal abscess, there's a higher chance they might have an underlying bowel disorder, like Crohn's disease.
Right, that connection again.
Uh-huh.
Okay, let's talk symptoms. What are the absolute telltale signs? What should someone be looking out for?
The classic picture is really significant pain, often described as throbbing in the perianal tissue.
Throbbing pain. Okay.
Yeah, and usually very tender to touch. Pain during bowel movements is another big one. You might actually see pus discharging or feel a distinct lump or nodule.
Any other signs?
Some people might also develop a fever, feel generally unwell, or perhaps get constipated because it's too painful to go.
And in babies?
In infants, it might just present as a swollen red lump near the anus, making them clearly uncomfortable or irritable. And crucially, a rectal examination by a doctor is key for diagnosis.
So the exam is often enough. How do doctors confirm it and rule out those other things? What investigations might be done?
Often, yes, that digital rectal exam gives a strong indication. But depending on the situation, they might do further tests.
Like?
Well, STI screening could be relevant. They might investigate for IBD or diverticular disease, or look into other GI issues if suspected. Sometimes a proctosigmoidoscopy, just a quick look inside the lower bowel with a camera, can be helpful.
And for more detail.
For more detail, especially if they suspect a fistula tract or need to see the exact location and extent of the abscess, MRI is actually the gold standard.
MRI, okay.
It's great for seeing those tracts and any potential sphincter muscle involvement. Transperineal ultrasound can also be useful in some settings.
Okay, found it. How do we treat it? What's the management plan?
The absolute cornerstone of treatment is prompt surgical drainage. You need to get that pus out to relieve the pressure and start the healing.
Strain it.
Essentially, yes. Alongside that, pain relief medication is obviously important for comfort.
What about antibiotics?
Antibiotics aren't always necessary for a simple drained abscess, but they are considered in specific situations, like if there's significant surrounding cellulitis, if the person is immunocompromised, or has systemic signs of infection.
Right. And what about that fistula link and recurrence?
Good point. To reduce the chance of the abscess coming back, any associated fistula often needs to be treated surgically too, sometimes at the same time as the drainage or maybe later on.
And there are different ways to do that.
Yes, there are various surgical techniques depending on whether it's a low or high fistula relative to the sphincter muscles, things like laying open the tract, or more complex procedures like an advancement flap or using an anal fistula plug. Research is ongoing too, with clinical trials looking at newer options.
Okay. So what's the likely outcome? What's the prognosis generally like?
Generally, it's good, especially with timely treatment. Prompt drainage is key.
That's good to hear.
Yeah. And there's an interesting point in the notes about children. Sometimes a fistula in a child might actually resolve spontaneously without needing surgery straight away. So that's an important consideration.
Oh, interesting. Avoid surgery if possible in kids.
Exactly. Watchful waiting might be appropriate initially.
Okay. And lastly, what happens if things go wrong or if it isn't treated properly? What are the potential complications?
Well, the infection could spread, potentially becoming systemic, which is serious.
Sepsis risk.
Potentially, yes. Developing an anal fissure that tear is also a possibility, maybe in up to 30% of cases, although early drainage helps reduce this risk.
Right.
Recurrence of the abscess is definitely a concern, especially if there's an untreated underlying fistula. And sometimes scarring can occur in the area after healing.
Okay, so quite a few potential issues if not managed well.
Definitely.
Right then. So wrapping this up, the bottom line seems to be that anorectal abscesses, well, definitely not pleasant, are very treatable. But getting that prompt attention, the diagnosis, the drainage that's crucial for a good outcome, and minimizing those complications like recurrence or fistulas.
Absolutely. Early management is key.
For more in-depth revision notes on this topic and loads of others relevant for the MSRA, make sure you check out PassTheMSRA.com.
And don't forget freemsra.com for free questions and resources too.
Great resources. Okay, let's leave you with a thought. How might a better understanding of the risk factors we discussed, things like IBD, diabetes, maybe even hygiene practices,
Right.
how might that knowledge actually influence preventative care strategies or even just patient education around anorectal abscesses? Something to think about. Thanks for diving deep with us today.